Okay, so we're going to take a look at how this case went in real time. One of the downsides of Corona is that we have not been able to do live courses. Hopefully that'll change soon. One of the things I enjoyed most about teaching is the live surgery aspect, and having to work with the mentor and the student doing these cases together, and imbuing that confidence in the student to be able to carry out procedures that are new to them. This was a case where this was a difficult sinus lift, as we talked about in the last video, but again, this doctor lives out in rural Minnesota, so there's no oral surgeons in the area. If he wasn't going to do this procedure for them, it just wasn't going to be done. So again, it's a doable procedure, but being able to work with somebody to give the confidence to actually get it done allowed us to do it. So as we discussed, we set up a surgical guide. We planned for a sinus lift for 14 and 13. We were going to kind of avoid the sinus, and we picked up a lot of information as we did it. And let's get into some of the x-rays of how we got this done. So one of the things I like most about this case is that it didn't go perfectly. It was a challenging case, we all knew that, but we were able to get it done. So again, we know that there are going to be complications along the way. I think we all learn more from complications than when things go absolutely perfectly right. So let's get into it. All right, so this was the immediate post-op when the tooth was taken out. And we see the septum here was significant, and we knew that was going to be an issue. And we saw it in the CT scan. It was kind of a wave that was left. It kind of leveled off a little bit, but it was kind of a wave that was left. And I didn't appreciate quite how important that was going to be, but let's take a look at what happened. So this is the initial osteotomy that was created, and we can see the osteotomy was done right through here, and we start to get a really nice lift, and everything is going just as expected. We've got our top layer of PRF. There's our sinus floor. There's our PRF and collagen, and here is our bulk of some allograft. All right, so everything is going really well. Fantastic. Here's the second x-ray that was sent during the procedure, and there was a feel of the spring back as you're packing the material in wasn't quite as significant as it had been before. So taking a check x-ray in between is a good idea. Again, there's a shear membrane. It starts to get lifted up, and it gets lifted all the way to the top. But then we have this unfortunate tear that happens at the mesial superior corner of the graft. So now we've got our membrane kind of in two pieces in that one spot, but still pretty well contained. And this is what you're looking for a potential tear. You want to take a higher x-ray and see, when you see this kind of smokestack appearance, that you've got smoke rising out of the graft, you know you've got a tear. And our tear really is in this specific spot. You see it's still pretty well contained on the distal, but you see the smoke is kind of rising out of this area, and that's where our tear is. So the initial gut reaction is, let's abort the case. We've got a tear, it's all over. But we got two things going for us. One is we choose a particle size that's small enough that it can easily clear out of the ostium. And again, we checked in advance, the ostium was nice and patent. We're using particle size, which is 250 to 1,000 microns, so it's very small. It's going to be able to clear out of that ostium easily. Again, there's debris that goes in and out of the sinus all day long. The idea of mucus is that it's going to contain that, and it's going to expel it either into the nasopharynx or into the esophagus, and it'll get expelled that way. But either way, debris is always expelled out. We want to use particles that are not going to be too big to block that ostium. That's where we're going to get into some trouble. So we avoid that completely. If we get a tear, we're not going to cause a blockage of the ostium. And again, here we have a small tear, but the implant was still able to go in. And you see we're pretty well contained. And although we do have that tear on the mesial aspect, the superior mesial aspect, this implant will still work. And the kind of darker area here, that grayish area, is our PRF or collagen. This area will still be well contained. In my experience, what we're going to get is about a lift till there. I think that'll be where everything will settle in. All this will clear out on the top, and we'll get it settled in area. If we didn't put the implant in, what will happen is that it'll tend to sink down, and as it sinks down, you'll get less actual lift. What the implant is doing is two things. One, it's giving us obviously the physical implant, but secondarily, it's keeping the rest of that membrane up, and that'll allow that clot to form around it, and it stabilizes that clot even further, and will allow the bone to heal around it. So this is going to work out extremely well, And again, it's just a matter of having the experience there and having I was there live with a doctor and able to talk him through this and say, don't abort, this will still work out well. So we see a problem. How do we solve this for the future? Obviously, we don't like tears. We try and avoid them at all whenever we can. So as I studied this further, I kind of came up with a way of how we can avoid this in a future situation. So there's our initial osteotomy, our floor of our sinus, and that's where the tear ended. But what was the stress point that caused that tear? So that happened really as the crestal floor kind of dips down and the membrane is trying to lift up. That's where it's going to hit its snag, and it's not going to want to lift. The point of least resistance is no longer going to be the membrane lifting off the floor. It's now going to be the top of the membrane tearing open. So how do we avoid that? So I think if we created a second opening in that most mesial area, and again, I'm going to start to do this in cases where I have that wavy floor, open a second opening, pack some collagen or PRF, and get another little lift. That small amount will allow our lift to happen a lot easier. So instead of having one dome, we'll have two. And again, those two domes won't intersect. They just will continue to lift that tissue off the floor, and we'll end up with a lift that's going to give us a complete lift, completely out of the way. The Schneiderian membrane will lift easily, and we'll have a lot more bone lifted, and I think we would avoid the complication. So again, this was a situation where, and even though it worked, we had a complication in the middle. We handled the complication. The case got completed successfully, and we learned something along the way. And really, those are my favorite cases. I was told by my great mentor, Dr. Sheldon Lerner, the day you do your perfect surgery is the day you retire. Meaning, if you're not learning from every case, it's time to hang it up, because there's always something to learn from every case. I learned a lot more teaching than I do even when I'm practicing my own, because I can look at it with a much closer eye than I have time for in my day-to-day private practice. And as always, you can reach me at INplantMSS@gmail.com, on Facebook, on the YouTube page, my website, which is all listed below. We're going to be running some more courses, obviously, in the future on Zoom. And any other requests specifically, please reach out to me. And as always, any questions, any cases you'd like to be reviewed, please send them in via PIO Big Box, and we'll go through them together. All the best. Have a great weekend.